So welcome to the workshop. This is the G part of what we call the Mind the Gaps framework. As Dr. Fazila earlier explained, we created this framework because we wanted to keep it simple for us to remember and also easy for us to work on what might be the gaps in our digital health systems. So gaps here have two layers of meaning. The first layer is gaps, which is something that is missing. And the second meaning is GAPS, Governance, Architecture, Program, People Program Management, Standards, and Interoperability. So the first part is mind the gaps, meaning you have to be aware or conscious of the governance, the architecture, the people program management, and standards. The second part, which is I hope by the end of the conference, we will have had some comments from you, is what we call the fill the gaps. Meaning, these are the things we can do right now, right after we return to our countries. Small things that we can do to improve our governance, architecture, people management, and standards and interoperability. So first part, we will practice menti.com by getting to know the people in the room. And in a way, it's our way of defining our digital health future together. So first question is, in which country do you live? Okay. Oh, Australia. We missed that. I think there are some people online that are also participating. So this is a word cloud. I think many of you are already familiar with the word cloud. The bigger the font, the higher the number. Very easy also for technical people to understand. Okay? I think Philippines will win here because we did not require a visa to come here or an airfare. But I think Malaysia, as we saw, Thailand, Nepal, Sri Lanka, Maldives, Kenya. Oh, we have Kenyan participating online. Japan. So Shinji Kobayashi is in the call. Thank you, Shinji. Okay, thank you. Thank you. Next question. In which city are you located now? And this is a way to find out those who are, I mean, all of you will answer Manila, of course, Makati. So this is an example of standardization. Because I would have answered this with Manila, but you answered it with Makati. Okay? Okay, so Bangkok. We have people joining from Waco City, Colombo. Wow, Colombo, a lot of people. Thank you. Hello, Health Informatics Society of Sri Lanka. Kathmandu. Kathmandu. No, when we opened up the digital health planning national systems, the most applicants were Nepal and Sri Lanka, and I congratulate them for participating. Okay, so here, what is your current affiliation? Are you with the government in the health sector, government, non-health sector, academe, private sector, non-government, not-for-profit, or a national or international development partner? Okay, so as expected, most of us will be from, and this is actually the target audience of AHIN, that we would get government as one of the key stakeholders of the network, because we know that the work is so difficult. Government alone, as Dr. Fazila said, cannot do it. They need civil society support. So AHIN is the civil society support to our government. So thank you for that. And so when we talk about mind the gaps in AHIN, it's not actually original. We just got it from the WHO ITU National eHealth Strategy Toolkit. We launched this in AHIN in 2013, our second conference in Manila. And we embraced this toolkit completely. Essentially, if you look at G, G is the leadership and governance at the top, governance, right? When you talk about people and program management, that would be the workforce. And when you talk about standards and interoperability, that would be the middle layer there. But if you look at infrastructure, standards and interoperability, and services and applications, they are positioned on the screen as one on top of the other. Why? Because first you have to have good infrastructure, which was our problem earlier. On top of the infrastructure, you need to have standards. And on top of the standards will be your services and applications. So to be able, and that's the architecture. That is the architecture that we're talking about. That alignment needs to happen. Because if there's a misalignment, then you won't get the full benefit of your digital health investment, which is very expensive, by the way. It's expensive, but if you do it the right way, you will get more benefits than the expense that government will pay for it. You'll have healthier people, less disease, lower hospital utilization, better outcomes. So I think it's, all of those are real benefits that we can achieve if we have good e-health, digital health governance. So now, from now on, I will use e-health and digital health interchangeably. And inside the WHO ITU toolkit, if you go to figure 5, they have a recommended governance structure. And they said that e-health is really led by the health sector because they are the end users. And then, can somebody refresh the other screens? Anyway, you're looking at it on your laptop as well. Then it is led by a steering committee, which is supported by an e-health strategy team. And then on the left side, you will see the stakeholder and reference expert advisory groups. I anticipate a lot of the AHIN members will be, members of the stakeholder reference and expert groups. But you also engage with the larger, broader stakeholder environment. And we'll have questions later on for these stakeholders. Can somebody refresh the 2 screens, please? All the screens, hindi nagre-refresh. Internet ko. So, are you seeing okay? Okay, so their laptops are synchronized. Okay, what is governance in digital health? We'd like to simplify it into 2 things, structure and function. And these 2 are basically for purposes of digital health decision making. Why? Because there are so many decisions that need to be made, and many of them are expensive. So it cannot just be Dr. Bunchay making that decision. It cannot just be Jai making that decision. It cannot be Merrick. It cannot be Alvin alone. It needs to be a wider group of people with public accountability to make that decision. We elected them into position. They were nominated by the president or the prime minister. And because of that, they have, so to speak, the decision-making capability to make for the whole country. Not all of us will be put into that position. Well, I'm hoping that some of you will become ministers of health, but we're fortunate that one of our first architects, Jovi Aragona, became the Chief Information Officer of PhilHealth. And that's no small matter to have an AHIN member at that level of position. So congratulations, Jovi. We look up to you for that. Palakpakan po natin. A big hand for Jovi. Jovi got certified in COVID-5 together with Dr. Fazila and TOGAF as well. Okay, next question. In your country, do you have a national e-health or digital health governance steering committee? And it's okay. Yes, no, I'm not sure, it's okay. We just need to know if you're actually aware of any such structure in your country. Okay. Good. So majority are saying yes, yes. The cat is going to get dizzy. Okay, 39, and this is on-site and off-site, okay, because there are online participants. Okay. Good. Okay, good. I mean, compared to when we started AHIN, I suppose the answer then was zilch or 0. So I think we're doing good progress and we have the data now. The people are saying that, yes, we have a steering committee. Okay, now, here's the question. In your country, which do you think are sectors that are currently, if you know, or if you are desiring of a steering committee, who do you think would be the sectors that would ideally be members of the steering committee? And this is not a comprehensive list. This is just, a list that I came up with just to get a sense of who to you might be, who you expect to be in a National Digital Health Steering Committee. It's a very big responsibility for, I mean, if it's a steering committee, they will decide, yes, let's invest billions here. Let's invest millions here. So it's quite a big responsibility. So we want to make sure we have the right people in the steering committee. Okay, let's see. Of course, health, that's understandable. ICT, followed by science and technology. Wow. Oh, private sector. And planning and economic development. Okay. And then 39, social security. Yeah. Yeah, that's science and technology. Social development, home affairs, education and culture. Good. Okay. I'm sure I missed some agencies, so sorry for that. But I think what to me, what's relevant here is that, of course, health and ICT would be there. But any insights from the audience about Dr. Bunchay? Any comments about this result? Microphone, please. In Thailand.
Actually, as I told our conference yesterday, I just finished doing the digital health governance mechanisms that fit for the Thai healthcare system, and recommended those to the policy maker. And we found that one first thing is that it should be led by health sectors.
Okay.
The second thing that we found that Ministry of Health cannot handle it alone. That for sure. And both politically and both for the expertise on that. That what we found from our research. The third thing that we found is that we have to involve Ministry of ICT, which is in Thailand called the Ministry of Digital Health and Society, and also the Ministry of Higher Education and Higher Research, and another similar to what we saw on that. And the third thing is that what we found, the fourth thing is that these mechanisms should be independent. Maybe the National Digital Health Independent Agency that lead by Ministry of Health.
So it's not inside the Ministry of Health.
That's what we found in our research by reviewing the Broadband Commission and also 5 countries like Canada, Estonia, Australia, and Malaysia is one that Philippines, 5 or 6 countries that we review, and we found that the governance is depend on the setting of the political in the country, how the country be the kind of the one country, or has the federal type, the strong local government, or not, the how the power is sharing. And then we found that for example, in Canada and Australia, there is our federal government and local, right? And they have the National Digital Health Agency. For like Philippines, not Philippines, for the Estonia, it's just centralized, something like that. And for the Malaysia, is not in Ministry of Health, but also higher for the Prime Minister as the e-government. and health is just one sector under those.
Okay.
So I think the Broadband Commission report on 2017 is really good start for the for the country to learn that. We start on that, and then we do the kind of the extensive interview, and then this is what we recommend to the government.
Okay. So now we will wait for the story from Thailand.
Yes. I will
Okay.
know that they are going to compete or not.
CP, please. Malaysia, what is the experience over there?
No, I think what I think that we need to look at is actually is the governance and the steering committee. They
Mhm.
do almost similar function, but there's subtle
Yeah.
difference.
Mhm.
Governance, you make sure that policy are implemented accordingly.
Closer.
But steering actually is to set the policy going forward.
Mhm.
I think if you look at that, actually the survey, the industry is quite important because by e-health, we are looking at convergence of health and technology.
Correct.
By that definition alone, is multi-sectorial.
Mhm.
So the health will have the insight, but the industry will have the technology, but they don't have the insight. So if you bring them together, and that's where you get the best of both worlds. I think that's where I
Nice.
think that
Yeah.
the steering committee will lead to
Mhm.
the way. And if you look and see the Southeast Asia, you're looking at the social development as part of e-health as well. Because we want to go towards knowledge economy. And when we look at knowledge economy, then we need to develop the health sector in the industrial. So
Together,
that they
together.
need to know. So the industry need to know what the government's planning so
Mhm.
that they have the insight. Then they can then achieve the small and medium enterprise go up.
Mhm.
By going up, then you have a social development. So I think that when you look at all this development, I think it's actually multi-sectorial.
Mhm.
Everybody has to come together.
Thank you. Dr. Shevmoni. Health and technology together.
Good morning. Good afternoon, Alvin, Madam Chair, and ladies and gentlemen from different country. It's very interesting that for me to join the question. Please go to the question.
In
Yeah.
your country?
I want to see your question. Yeah.
Yeah. Sorry.
This is the point that I want to mention in this AHIN workshop.
Yes.
The question one, your question do not fit to me that you could answer the question.
Okay.
This one.
Why?
In your country, you say you want to ask my country which sector is a ministerial health example.
Mhm.
And digital health could not, digital government could not happen because we should have digital health government first. If we don't have digital government, we do not have any governance.
Mm.
This is the point that I want to mention. So that my country, Cambodia, has on the process to develop digital health government.
Mhm.
And we have a steering committee under the management of Secretary of State.
Secretary of State.
Yeah, Secretary of State. We have steering committee.
Mhm.
And the point is that if we create the digital health government already, then we can see the digital health governance later.
Nice.
We have not the government, and then why we want
Agree.
to see the governance? So
Good.
nothing to see. This is the point. And I'm not like to want to be a victim of the question. Your question should be concerned to my country.
Yes.
Otherwise, I could not answer. And why I come to join for answer, not
Welcome to the
to
Philippines.
wait for somebody then boring me to answer. This is the point. Yes, thank you.
Thank you. A big hand.
Yeah.
Maybe next year, the general meeting will be in Cambodia. Okay, thank you, Dr. Shevmoni. Actually, the Secretary of State right now is a former AHIN Working Council member, Dr. Kiri Lo Viesna Kiri. Yeah, he used to be the AHIN Working Council member for Cambodia. Now he is the Secretary of State. That's a clue to AHIN. That's why we have the GM next year in Cambodia. Okay, from your perspective, this is free text. No? Just type. What are the roles and the responsibilities of the National Digital Health Governance Steering Committee if you can type more than one. If you were listening to Dr. Fazila earlier on, there are at least three, three roles of the steering committee. Please don't be afraid. We will not see your name here. Ooh, COVID-5. Evaluate, direct, and monitor. Regulatory policy making and animation. Setting concrete strategic direction. Set the guideline and standard. Policy e-health. Set directions for growth of e-health for UHC and equity. Policy direction, regulate and monitor. Can you imagine a bus and then there is no driver and there is no direction? It's a useless bus. So the bus, if you think of bus as technology, you know, like a school bus, you need to have a competent driver who knows where they are going. So I think that's what we need in every digital health governance in the country. We need drivers who will take the whole country inside the bus and safely tell us this is the way we are going forward. And so I think, thank you very much for what you shared. I think I go for evaluate, direct, and monitor because those are the COVID-5 roles and responsibilities of governance structures. Thank you. Yes, Dr. Butchay.
I just to add a little bit, I forgot one point that there is three major mechanism for the governance, like the totally Ministry of Health lead. The second one is the e-government, like the e-government lead, and the third one they call the mix or the hybrid one. And what we found is depend on the culture, depend on the politics, and depend on the kind of the government. Like if you are the kind of the dictator or the democratic, and they will fit around this spectrum. And I think there is no one size fit all. You have to go and understand the healthcare system or health system in the country, and then look at the spectrum of these three governance mechanisms. And maybe you need to be one of the two part of this. And the stakeholder involvement is like CP Wong said. That's what we found, but we don't know that what we suggest to Thai government, to Ministry of Health of Thai, that you should lead, but get people involved. And we saw the success of Australia, UK, the Canada, or the Democratic. So the independent national digital health agency might be one of the one of the mechanism that should be considered. And I may translate my study into English, and then we can share about the study that we do in Thailand, and you can use our how we do that, and finger crossed and think I brace for Thailand that I can they will follow the recommendation that we as a community in Thailand recommend the government. Thank you.
Thank you, Doc. Can I ask Klube? Klube, in Hong Kong, what's the governance structure? I know Hong Kong is quite ahead. You have an e-health consortium. Very quickly.
Yes, I think that for Hong Kong, the structure is about the government encourage the e-health record to sharing between public and private. And the government...
Public and private.
Yeah, public and private. And the government provide a clinic software free of charge.
Free clinic software.
Free clinic software to the clinic. Let the clinic to upload their data to the government.
But the clinicians, they don't know how to install the software.
So they partner with the private sector, like my company, to provide the service to the clinic to install the software, data migration, and others.
So government creates the software and engages with private companies to help the clinicians use the software.
Use the software.
It's still the government software.
Yes.
But they don't have the capacity to go to all the clinics.
Yes.
So they engage you.
Yes, yes. Okay.
Thank you. Thank you. Thank you very much. Next question. AHIN encourages each country to have a blueprint or a national health enterprise architecture? Do you have access to your country's blueprint? Okay. And I think one of the projects we will do for 2023 is we will get the cooperation of all our members and we will start compiling these artifacts. Your governance structure, your blueprints, because the blueprints are supposed to be available. No one will be able to follow the blueprint if it's not available to the people who will follow the blueprint. So one of the principles of the blueprint is that one, there should be one so that people will know that there's a blueprint. And second, they can access it so that they can follow the blueprint. Okay, good. So majority, yes, they can access the blueprint. Some are still not able to access the blueprint, and a few are still not sure if they actually have a blueprint. Okay. Yes, Dr. Fazila. That's your session tomorrow. But maybe somebody from cannot access the blueprint. Can somebody volunteer? Why can you, is it not on the MOH website? Yeah. What, Dr. Fazila, what do you do with your blueprint?
Sorry, I'm more interested to know
Mhm,
why they don't have access to the blueprint.
mhm.
A blueprint is supposed to be shared and everyone must know about it.
Ah, okay. So you're saying if they know that there's a blueprint,
Yeah, why?
Okay.
Because I'm the 13 people who have answered,
mhm,
they know they have a blueprint, but they have no access.
maybe they don't have internet right now.
No.
I'm kidding. Who answered? One of the 13.
Yeah.
Oh, okay. Raj,
Yes.
Raj will answer the question.
Okay, that's one question.
Okay.
But the 15 definitely no blueprint.
Yeah, maybe they just don't know that there's a blueprint, or
Or not
second,
sure.
there's really no blueprint.
Okay, not
So
sure.
they're not sure.
That also would be interesting to know.
Okay.
Why are you not sure you have a blueprint?
Yes, yes. Okay.
Yeah, because you are in digital health.
Okay.
I'm assuming the participants
So
are
if-
people who are interested in digital health.
If you are a digital health advocate, you have to look for this.
Yes, you have
Yes.
to know for this. So
You have to ask for it. Because what will you do if you don't have the blueprint? You will be creating something that might be offline. Dr. Raj
I
Podel.
think there is some confusion with the questions. There's a questions. So actually, we have got blueprint for e-governance master plan, and we have got the e-governance architecture.
Yes.
We have got whole.
This is Nepal.
Yeah, this is in Nepal. So inside e-governance architecture, we have to develop the digital health.
The
That
health
we don't
specific.
have. Yeah, health is specific. We don't have that one.
Okay.
But overall architecture that we have in place, and that is adopted by all the private sectors even.
That's interesting. They have a government architecture, and now their next step is creating the digital health part.
Yeah,
Okay.
because in our governance, we have got a digital Nepal framework.
Yes.
Digital Nepal framework is one of the
Overarching.
That's a eagle view perspective.
All of
also.
society.
Also, that have got 9 different pillars.
Okay.
So one pillar is the digital health.
Okay.
So inside digital health,
That's
we
the
have
next
to
step.
work on the blueprints
Okay.
and other standardization.
So that's why you answered no, but actually there's an overarching blueprint already
Right.
to start from.
But
Okay.
not because you have written there digital health.
Yes, yes.
But I don't have digital health.
I
That's
understand.
why.
That's my fault.
Yeah.
The question was ambiguous in a way. Yes, Jai.
For India, like we initially used to have a national health plan, and then that once the digital transformation efforts started happening, so the national digital health blueprint came into picture. So that's like a mother document that is now used as a reference for the national digital health mission.
Mhm.
And then now actually what is happening is every policy related decisions, whether it is unified a health interface or a provider registry, or for that matter any other like health data management policy, everything is now a public document. There is a public consultation that happens with multiple sectors. The working document or the position papers that is available actually on the website of the National Health Authority for people to actually critically comment.
So even before it becomes official, the drafts and
Ex-
comments are already available.
Exactly.
Okay.
So that is a process of involving people now. The government is taking effort.
Okay. Thank you. Thank you. So it's not keeping it under wraps while it's not yet final, but really during the development process, engage the different stakeholders during the drafting until it becomes final.
Exactly. So there is a workshop to introduce, and then there is a working draft that is available for the public to look up and comment till it becomes final. And even after finalizing that, it's available in the public domain.
Thank you, Jai. Dr. Bunchai, short only.
Very short that one possibility, like some country, there is so many blueprint.
So many blueprint.
Yeah,
that's the
because
other
of
end of
they
the
cannot,
problem.
they cannot get the consensus.
You don't
But-
know which one is
Yeah,
the...
which one is the country? Because of you don't have governance.
Oh, okay. So each group is trying to create. So let me just be candid with the group that, in the Philippines, it was the health sector that was the first one to come up with the health sector enterprise architecture. And then when we approached the national government, this is like 6-7 years ago, they said, just go ahead, continue with what you're doing because you're already organized. And maybe we will just have a federated enterprise architecture. So that was before the current government. So we will see. We are actually waiting for the new government. What will be the style of the new government in the Philippines? True or false? The National Digital Health Governance Structure, members, roles and responsibilities should ideally be accessible at the MOH website. This is a no-brainer, but I just wanted to see if there's a differing opinion. Okay, let's go to... Okay, I think... Okay. Oh, one... Okay, now I have to call you. I have to call the two people who said false. If they're not inside the room, then they are online. Can somebody explain himself or just answered false for the sake of testing whether it's actually the button is working? Thank you. At least we all agree it should be transparent. Agree or disagree? It's similar to the previous question. The National Health Enterprise Architecture or Blueprint, and again, I think Raj will will say no because it's not yet there. They have the national one, but not for the digital health one yet. Okay. And this is also obvious because if we ask if you want to ask the different stakeholders to create services and applications that are interoperable with each other, but you don't give them a blueprint, I don't think that's fair. It's like telling them, you have to be able to interoperate with each other. Goodbye. It's not enough. Government, how do you do it in Malaysia, Dr. Fazila? The blueprint is regulatory sandbox or to
No, because Ministry of Health, I told you it's separate. It's the public and private is separate. So Ministry of Health, we have our digital strategic plan, and it's done every 5 years, 5 years period. So of course, we bring all the stakeholders, and we have multiple workshop. And in better times, we used to have consultants, but now we don't have consultants. We do it ourselves. But we also now have included new things in the strategies, and so everyone knows. And then we launch it so that everyone is aware of it, and then it's uploaded in the website, and it's monitored. We have a committee that monitors the action plan in the blueprint. So there is
a separate group.
The action plan is a separate document where we must have all the action plan for the next 5 years, the funding, the whatever you need to go.
Who's responsible?
Who's responsible? And then there is a governing committee that monitors it quarterly for that whether you have
For
achieved
performance.
for performance. And then because it's a 5 year, we have a midterm in the 2.5 years. Where we can either drop some activities or add. So that's how it's done. So it is properly governed.
Okay. So when you get that election again, that will reset it back to zero. I'm kidding. Okay, so we talked about governance structure, and now we'll go to governance and function. In a way, you already answered this earlier when I saw evaluate, direct, and monitor. But how often do you think should these steering committees meet ideally? Ideally. Of course, we know they're very busy people, but if we had a say, because we are citizens of the country, we expect you to meet. Choose one. How often would you like your ministers to meet? Wow, you're making them work hard. 4 times a year, quarterly. Yes, quarterly. Yes, yes, quarterly. Oh wow, look at that! It's a normal curve. 4 times a year, twice a year. In general, the more frequent is the better, right? Because you can keep tabs on what's happening on a more frequent basis. But of course, they have to make time for it. They're all busy. They all have their own different things to do. But this is why I think Dr. Buncha is suggesting it needs to be higher than just the Ministry of Health, because it cannot be just a Ministry of Health activity. It is a multi-sector activity. Thank you. Thank you. 4 times a year. This is a hard question, and don't rush it. So I prepared, I followed the WHO ITU National E-Health Strategy Toolkit on what are the activities that a steering committee will do. And I think you will choose all of them if I give you check boxes. So I did not give you check boxes. Rather, I am going to ask you to rank priority. This is a little hard because now you have to choose. You have to read them first, all of them. And then once you've selected, choose the first one, the most important, and then the second one, and then the third one, and then we'll discuss why you think this one is more primordial than the others. Okay, I think we're seeing a winner here, but let's wait for more people. This is a very complex question. Fit for a digital health group like AHIN. Let's get to, we have, I think what it's doing is it's counting all of the total votes. But I'll give you time. At least choose 5. Because you can choose. No. I'm sorry. What I meant was number 1 should be the most important, and then you can choose more after that. You can choose more. That's why when you choose one, there's another box that opens under it. No? Okay. Okay, so everyone is now choosing create and empower a national digital health strategy team. And if you look at the WHO ITU toolkit, that's actually the group under the steering committee. Because the steering committee are ministers. So they're very busy people. You cannot tell them to do this and do that. So there must be a group of people who would be, listening and getting instructions from the ministers. So this would be the vice ministers, the directors, the managers, and that will be the National Digital Health Strategy Committee. But there are also publish the National Digital Health Strategy. And then the third one is propose laws and policies for digital health. My comment here is that this number 9 and number 7 are possible if you have number 30. If you have this group that's actually working, then all the other options here are actually possible. But if you don't have this group, who's going to do the National Digital Health Strategy? Who's going to write that for approval of the minister? Who's going to share the National Health Blueprint? Who's going to encourage the development of capacity building? So it starts with people. So in AHIN, our mantra is we start with people interoperability. So that's the last item over here. The choice is to create that national e-health strategy team. So that's very important group of people. They will be the one to do the heavy lifting, so to speak. So in the Philippines, we have the eHealth Program Management Office. They're the one that manages the day-to-day needs of our eHealth program. Okay. Now, let me point you to the box on the left, which is part of the governance structure. The stakeholder, reference, and expert advisory groups. Do you have expert reference advisory groups in your country? For example, interoperability labs or other groups in your country that are helping you achieve your mission. If you do, please type the name of the group, not yes or no. Sorry, the question is, the first question, the first part is a yes or a no. But the real question is, what is the name of your group? Because we will try to invite them to join AHIN. We need to invite them to join AHIN because these are the people vested in digital health in your country. So we'd like them to also be part of the network. Okay? So obviously, we have a lot of people from the SILAB. There's SINAG Solution. MREG. MREG, by the way, is in the Philippines, we have the Electronic Medical Record Experts Group. This is the collection of electronic medical record developers. So they formed themselves into an expert group. DTO, I think this is Indonesia. Not sure, no. Thailand, finally. Dr. Rat, thank you very much for that. So PSDH is the Philippine Society for Digital Health. So we just formed that last year. And our vision there is just to communicate what's the latest on digital health in the Philippines. So this October 15, we will have integrating the health data governance principles into Philippine health education. Vietnam, HIS Vietnam with Oslo University. Okay. Mampu, Emranti. Can somebody explain what this does? Emranti. Somebody from Malaysia, the boss. What is Emranti? Microphone, please. Microphone.
Okay. Meranti stands for Malaysia Research Accelerator, something technology innovation. So
It should be letter S, not letter N, if it's something.
So this is an agency that helps in accelerator programs for new technology and innovation, and they have created the Health Tech Hub.
Health Tech Hub.
So Ministry of Health have identified 5 hospitals for technology players, and so to as a test site, test bed before commercialization. So we facilitate in terms of regulation. They also give funding and grants.
You give them money?
They give, not
Okay.
Maranti gives, you know.
Maranti is a
It's an
separate
agency, yeah.
Okay.
So that is Maranti. Then the National Regulatory Sandbox is also is a platform, but it's at the national level. So any sector, including health sector, who wants to try out things can go to this sandbox. It is also facilitated by them. So, Maranti stands for Malaysian Research Accelerator for Technology and Innovation. And then, of course, Mampu is a government agency that they have experts and SMEs and also consultancy to help governments in any digital technology.
Okay. Gang, the gang of Dr. Fazila. Oh, okay. Okay. Okay, you're here. And then Amakumaya? Amakumaya, something about Amakumaya, please. Amakumaya,
This is the mother's love, meaning.
Mother's Love.
So this is actually this is providing the support during the COVID. It has provided the by developing the software standard and to the government. So this is non-profit initiative, from the public health and engineers.
Thank you. So for those who type something here, you can type the description of this organization in the chat box in the Zoom. If you're coming from the Zoom group, I see Medis DC, DSIH France. Did that come from you, Solen? Okay. 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 We can get more information later from you. HL7 Australia, the UP Masters in Health Informatics, Oslo for DHIS2, Standards and Interoperability Lab Asia. UGM is University of Gadjah Mada, Paanis. Thinking Machine is in the audience. Thank you. Thinking Machine is an AI company in the Philippines, startup. Correct me if I'm wrong, just type the description for your groups in the chat box. Okay, thank you. Can we project the screen, please? Next question. Technology failure. You have reached the end of the presentation. Impossible, because I have more questions there. Okay. So we talked about this stakeholder and reference and expert advisory groups, but there's also on the other end would be the bigger group, broader stakeholder environment. And I think there was a mix. Some of them I saw already in the previous question. But if you have any more groups in your country, Dr. CP Wong, I know we were discussing this earlier on.
Yes, I think this is actually a policy maker. But as I mentioned again, I think that when you talk about e-health, it's a convergence of health and technology, and there's a big, huge sector that's ready to propel the country forward. So in this aspect here, I think the policy maker alone will not be able to make something without the involvement of other people. So I think that's the first thing. The second thing, that if you look and see, increasingly healthcare is privatized. So I think in a lot of countries, certainly in Philippines and Malaysia, where we have a huge, significant private sector. And the private sector, obviously, their main goals is slightly different from the public sector, but they must be involved as well. Because just like saying that if you run alone, you can move fast, but you want to move together further, you have to move together. So you need to get a private sector. In this aspect here, the private sector will be quite important to actually propel it forward. So I think in that case, I think we must have actually the private sector and other stakeholder. The academics is quite important. I think
Why?
why? Because I think as an academic myself, we think a lot, but we don't do. So we think when we think we have the idea and so on, some of the idea will be applicable, right? And so I think that actually again contribute to the sector.
Yes.
And again, just now we have the survey where I think a big sort of portion in the audience think that industry should be involved as well. So I think the non-government sector is actually quite significant. So I think we should get them involved.
Okay. While you're there, some people have been answering, can we project the, for the question, do you have digital health advocacy groups? And I see Digital Health Malaysia,
Oh, right. Okay.
which you were not possible to type because you were there. So
okay.
what is this Digital Health Malaysia?
Right. I think in Malaysia, what we have done actually is that we have actually set up an association called Digital Health Malaysia, which is non-for-profit to complement the government. So I think that, and that actually is actually a progression. So I think Dr. Fazla will tell you that initially when we started about 7 years ago, we have a lot of idea. We come together and we form actually a telemedicine development steering group. And that steering group, then we eventually break it up to a policy where Dr. Fazila and her team in MOH takes part. But we also acknowledge that there is actually a need for actually a private sector to support it. And so we actually then formed Digital Health Malaysia to actually complement what are the policy that's coming out from the public sector to actually sort of align ourselves. Because that, again, I think is quite important as well. Because if you look and see again and again in the discussion that we have been talking about, the alignment is important. I think if you do not know what's going on in the government, I think you can't do it properly, and you duplicate, you waste your resources and waste your money. So I think that's why I think in Digital Health Malaysia, what we have done actually is that we bring the industry, the academia, and other people together, and we work very closely. As Dr. Fazila says, that she is actually we have a love-hate relationship. I love her, she hates me. So we work very close together, we communicate. So I think if she doesn't hear from me, she'll give me a call and I'll call her, and then we discuss what's going on so that we can align ourselves. And that's quite important as well. And then when we have our own conference, like this type of conference, we can always count on her to support. So that kind of collaboration is very, very important.
Yeah. So Digital Health Malaysia is like, so there's one group would be the policy making, the other group would be the implementers, and you bring them together so that there's the alignment between the policy and the implementation.
Correct. Excellent. And that's precisely what we want to do. And also the industry. We look at the industry as a very important one, because industry, a lot of time they have the technology, but they do not have the insight, what is required. As a sort of
The strategy.
Yes.
They don't do. They will not do the strategy. Government will create the strategy, right?
Even that also.
But they need to know that.
That's right. And even a simple thing, for example, a technology, a technician, I mean, the company knows to build the best technology. But as a physician myself, I think I will look at it and say, how can I use it for my patients? But that may not be the top of the range technology. So, and that is the insight that the industry people need, I think. So that the industry say, hey, I know exactly how to do this, or dancing or singing things, right? But then I think if that's not what the doctor wants, your product will fail. And that product will not be used. So you have the innovation, but the innovation will not be used, right? And so that's why industry need the insight of the physician. The physician needs the technical expertise of the industry, and also the funding mechanism. So I think that's where I think that we should align that. I think quite important. I think for that's why I think I'm for in Malaysia, what we do is that, and we have actually been saying that for 7 years now, is that it has to be an inclusive ecosystem, everybody coming together, right? And we are hearing yesterday and today, donor alignment. The alignment is very, very important. That we must know exactly where we are moving, so we can we can sort of center our resources and becomes actually more cost effective.
Thank you. DTO, Chemcast, Go ID, Paanis. Microphone, please, at the back. DTO.
Yes, thank you very much, Alvin. In Indonesia, we started a new initiative. Several ministries started by Ministry of Education, Ministry of Finance, and finally the Ministry of Health started to develop a new ad hoc team called the Digital Transformation Office. And in this team, usually the staff are not the civil servant, but they are recruited from many industries. And currently at the Ministry of Health, the team is about 200 usually young, high-tech team.
They're not government employees.
Not government employees, but it is also important the role of a development partner, because Ministry of Health is looks like a team to develop the partnership. I think one of them also supported by USAID, World Bank, and other. And then this new team are supported financially, mostly the like a consultant, but they are working directly inside the government. It is quite different that before usually consultants are outside of the government, but right now they are trying to develop internally with the Ministry of Health. But there is also an issue that this team are not permanent staff at the Ministry of Health, but working together with them, and also how to deal with the conflict between this team with the civil servant are also important. But also on the other aspect, how to maintain the conflict of interest, because some of them formerly are working in the industries. So when there is a bidding or program, how to prepare that this team are not like insider trading or something. This is also important. But this is, I think, important in when we are talking about the transformation. If we are talking about the jargon of transformation, but not transforming inside the institution. Probably we can see that all the transformation are outside of the building of the Ministry of Health, but inside the government it's also important. And one more thing, it is also the first case in Indonesia that our Minister of Health is for the first time is not from the health background. He was formerly a banker and with the financial background, and then I think it is because of he come to the Ministry of Health like come to the jungle and do not have the team. So that's why the digital transformation office is coming. But I do not know whether it is a specific case, but the idea to transform the organization is also very important. Thank you.
Anis, while you're there, so wasn't that? I mean, I see the benefit of bringing fresh people into the system.
Mhm.
How did the government accept that? What was the reaction of the Ministry of Health personnel?
Yeah, there's also always a pro and con.
Yes.
For example, in many discussion, it is also mentioned about it. It looks like jeopardize the existing civil system, civil servant cultures, and the building team. But at least if they could work together, they could bring a new concept. For example, this is the first time that in the new blueprint of the Ministry of Health, the concept of enterprise architecture is well described and well written. And via itself 7 already started right now with the many support, especially with the industries.
Yeah.
So there is also some interesting result. But on the other way around, this team usually mostly from the non-government, they should learn fast about how to prepare the bidding process comply to the current governance financial mechanism.
Yeah.
It is not easy. So I think this team should work together because they're still working in the government. They should report to the minister, and minister still need to be audited by internal auditor at the
Yes.
international Indonesian Financial Service Authority.
Thank you. So it's a change. It's a
Yeah.
change that will work in some ways and also will be taken negatively in some ways. But
Yeah.
it's change that will happen. Thank you. MDEC. Who typed MDEC? MDEC. MDEC. Anyone? Yeah. Dr. Fadli.
MDEC is actually a Malaysian Digital Economic Corporations.
Mhm.
So if you're talking about the digital health, this one before is basically provide a digital environment for the whole Malaysia ecosystem, the digital economy. And then one of their strategy is to uplift the digital competency among all knowledge worker in the Malaysia. At the same time, they are talking about the regulations. They are talking about the collaborations between the privates and the governments. So basically, MDEC in Malaysia, they provide the digital environment for both the governments and the privates. And then we have the Ministry of Health. They provide the policy and directions for the digital health over the sides of the governments.
Mhm.
We have the DHM, the society and the implementer, both for basically the coordinator between the privates and the governments.
Mhm.
So that's how it happened in Malaysia. There needs an organizations that look into the whole environment.
Mhm.
They uplift the digital environment, and each sector got their own policy making, the regulations and all, and they got the society who look into the coordinations between the governments and the privates.
It's like an ecosystem.
Yeah, it's like
being,
an ecosystem.
Thank you, Dr. Fadli. Digital Health Sri Lanka. Sri Lanka, Dr. Palita.
Yeah, we have a digital health health steering committee chaired by the Secretary Health, and there are few working groups, technical working groups. Now, as few of them mentioned that very high level meeting is chaired by the actually stakeholders are very high level officials which are not really tech guys, tech people.
Yes.
But so It's basically as the health information unit is the kind of a hub where all the technical work happen, and we update the steering committee on the progress of the things. And again, probably we going forward, now we have already developed the first version of the digital health blueprint, and we involve a lot of stakeholders, government and the ICTA and the private sector, academia, and many other people. And we are going to finalize by December with the wider consultation with the public also. So in line with that, governance also probably need to strengthen, because we see some gaps in the governance mechanisms. So one part of this, the Mark Landry mentioned about this State to Health project. One part is the development of the governance framework and governance mechanism. So that's a kind of a structure we have at the moment.
Thank you, Dr. Palita. By the way, your enterprise architecture document is very good.
Thank you.
If we can share it, let us know.
I think
So,
we have already shared with
Dr. Pramod.
Yeah. Okay.
I think with the assistance of Mark Landry with WHO, you were able to come up with a national digital health enterprise architecture, which I've been hearing a lot of good words about the enterprise architecture. Congratulations for that. I don't know if there's somebody from Philippine Society for Digital Health here. Nelson? Philippine Society for Digital Health. Can you say something about the society?
Hi, good afternoon. I'm Nelson. I'm from the Philippines Digital Society, Society for Digital Health. We just established with Dr. Alvin Marcelo, Dr. Iris Tan, and Ariel Betan, and Dr. Millicent Ong. So we are the 5 founding members. So what we started since last year, we started organizing EMR sessions in terms of trying to educate the private and government what the government has, and educating it and relaying it to the private communities or to the private sectors.
Like Digital Health Malaysia.
Like Digital Health Malaysia. So again, as Dr. Alvin has been mentioning earlier, we're going to do a session this Saturday on health data governance by Transform Health. So we're looking at the opinions of academe in terms of going about this, and then we'll roll out more of these stakeholder liaison management sessions with everybody here in the Philippines to educate a lot. Yes, sir.
Thank you, Nelson. Let's hook up with, go ahead, Dr. Fazila. Stay there, Nelson.
It's interesting because you just started like a year or two. They also just started.
Yeah.
And then we have other countries also have their society.
Right.
Maybe AHIN can be a bridge where we bring together all the societies.
Yes.
And you can do a lot of things together and not duplicate. So maybe that's one thing.
That's a good suggestion. So Nelson and Dr. CP, we need to come together. 2 nodes, and then 3, and then 4. Maybe Mongolia will have a group. Died. So actually in the audience right now, we have Dr. Bunchay from the Thai Medical Informatics Association. Can you tell us more about what you do at the Thai Medical Informatics?
Actually, there is several advocacy group and also the many group in Thailand that do the digital health. In Thailand, we have a long history of the Thai Medical Informatics Association, and we have a annual meeting every year. The products that we just created is the hospital accreditation for health IT.
Can you repeat that?
The hospital, we call HAIT, the hospital accreditation for the health IT, which means that we look at the component for the health IT in the hospitals, and then what is the kind of the infrastructure, the how to handle the how to align the policy between the hospital and the IT office, something like that.
Yeah.
So it follow the hospital accreditation like JCI,
Yes.
but it's more on the health IT side.
Okay.
And that is the products that the Thai Medical Informatics Association developed in the last 6 years, and now it roll out to go to the hospital. Kind of the one is educate, another thing is to certify.
So how do you do that? Hospital A will evaluate Hospital B.
Uh,
Hospital B will evaluate Hospital C.
it run right the HIMSS, the
HIMSS.
MRAM.
MRAM. So there's
Yeah,
a,
there
there's a
is
group of people.
The group of people in the
Ah.
Thai Medical Informatics Association, like the expert,
Wow.
going to the hospital.
Mm.
So we have a long history of the hospital accreditation, which is the JCI version of the Thai.
Yeah.
So
For
Thai,
quality.
we
For
all
hospital
over
quality.
the every hospitals.
Mm.
But so this is in Thailand, the HA and JCI is just competing. Another
Yeah.
one is international one, right? Where you
Right.
have to spend a lot of money for the
Yes.
accredit. But this is the local one,
Okay.
and it had been supported by the national Ministry of Health and also the
Okay.
the National Health Security Office.
So there's funding support coming from the Ministry of Health and NHSO for
No,
hospital.
it kind of the independent. They can
Independent.
sustain by creating the training and something like that. But
Okay.
once the hospital certified by the hospital accreditation, then the reimbursement model is kind of the add-on for the regular thing. So it has the level of the accreditation. If you have a higher accredit, like you have a
Oh, you
quality,
get more
you
you get more
kind of
reimbursement percentage
5% more or 10% more, or there is a
because
some-
you are able to get accredited.
yes, in terms of the quality.
Okay.
And the health IT follow those kind of the model.
So wait, so in Thailand, hospitals get different reimbursements depending on the accreditation level.
Let's say that get add on the reimbursement.
Add
not
on.
not they don't have the different model
on,
for
right, right.
reimbursement.
Same
but
reimbursement,
If you
but-
accredit, then you
Yes.
have a little bit kind of the advantage
Add-on,
to give
right.
to incentivize the
Right.
hospital to be more
Yes.
accredited because of
Add-on, yeah.
all of these
Correct.
volunteer.
Yes.
It's not compulsory. It is volunteer.
Okay, so it's an optional.
Yeah.
Oh. And if
But-
you get the accreditation, NHSO and ministry will give you a little
Yeah.
extra.
Something like that. So,
Very
but
good.
but this is the model that developed for 20 years,
Yes.
and IT trying to follow this model
Yes.
by get the health IT office in the hospital
Yeah.
to kind of the upgrade their the capacities.
Mhm. Thank you. Actually, that's a very good idea. You know, some hospitals have already approached me like, can you help me set up the hospital IT? Because it's hard. There's a lot of components and a lot of the laboratory needs to connect to the pathology, the radiology, to the EMR, and then the billing. So these are very complex setups that. So I'd like to learn more about the hospital accreditation, Dr. Bunchay. Thank you. Okay, so I think we'll go to the last question, which is, what is your vision for digital health for your country? And this is now personal. This is now personal, and I'll give you time to answer this question. And I think this is very important because in the end, the people running the digital health show in the country are just people within those countries. So some of them are create a big data door referrals management through interoperability. I think that's like a database, no? Inclusive and progressive digital health. Open source communities and non-government organizations centralize and utilize standardized, accurate, and timely identifying true stakeholders. PhilHealth will eventually adopt FHIR for the health information exchange. PhilHealth is our national health insurance agency. By 2027, establish an effective and efficient digital ecosystem that ensures quality health services by allowing everyone to make informed decisions about their health. That's nice. Sustainable and centralized. Improved quality of care at public and personal levels. Linked HIS system across country with interoperable systems. Can I ask the audience, has anyone actually achieved this already? Where so hospitals will have their own respective information systems, and they do because they need it. But are they now able to link with each other, or more? Because in the Philippines we can link up to PhilHealth, but we cannot link up to the other hospitals yet. How about Thailand, Dr. Bunchay? So you have a majority of Thai hospitals are government owned, right? But are they able to now share data across facilities or just NHSO? And then Malaysia, and then Indonesia, and then maybe Sri Lanka and Nepal.
That is our dream.
That is your dream.
That is our dream. We have do this for 20 years.
Okay.
But in terms of the administrative data,
Yeah.
I can say that we are now able to exchange and then across healthcare facility of the country.
Hospital to hospital.
If they want to, but they don't. They don't. But they will exchange with the National Health Security Office and the insurer.
Of course,
And
because it's for
for the
reimbursement.
money.
Yeah.
But in the province, if they want to share among the hospital, we already have the standard.
Oh, you say you
for-
have the standard already, which is what the message that you sent to NHSO.
and the insurer. We have three
Insurer,
measures.
So they can also send that to each other
if they want to.
If they want.
If some province they kind of the gather all this kind of the information and they let share to another hospital, another health facility. It depend, but because of it can be exchanged with the insurer. So those kind of the data, if they want to exchange, they have the medication data, they have the laboratory data.
Right.
If they want to, but right now, still not have the structure to share the clinical data.
So can you explain why in some areas of Thailand they're able to do that? What is the difference of that area? How
It's-
come they can exchange data using the standard format, while other areas they're not able to do the sharing, even if they're using the same standard format? What's the difference between that area that you mentioned?
We have 13 regional health regional sector from the 77 province, and it depends on the head of the health superintendent
Of the region.
of that regional.
Yes. So that's the difference.
Yeah. So
There's
the
governance and
superintendent, if
leadership at the
they-
regional
Yeah,
level.
if they can talk to the chief
Mm.
of the provincial
Mm.
officer and then the director of the hospital,
Yeah.
and then they have the indicator that they have
Mm.
to monitor. So they kind of they will bring more like both policy and also the support for the hospital.
So this is an interesting thing. In Thailand, they already have a standard messaging format where the hospitals send it to their national insurance agency. So essentially, there is the potential for facilities to exchange information because everyone is using the same standard format. But in the 13 regions, it's not happening except in one region because of leadership and governance of the region. There is a regional level leadership and governance, and because of that, they're able to exchange the data for specific purposes. That's a very good insight. It's not just national leadership and governance. There's also local leadership and governance that actually makes it more effective. because now they're making the health system and the health governance work in their local area. Pay. Microphone, please. Microphone, please.
So, yes, Doc. So, and that's why it's very important to also look at this, at the digital health at the subnational level.
Yes.
In one of the provinces where we operate, for example, we developed a COVID system, a pattern after the DOH system that would allow facilities and LGUs to monitor the bed capacity, PPE supplies. What we found out after a quarter of the rollout, the statistics do not move. The dashboard, the PPE supplies, for example, remained roughly between 30 to 50%.
Mhm.
And then when we had the local health board meeting in this particular province, the reason is that their supply officers, the chief of clinics, specifically instructed them not to be transparent with the supplies,
Mhm.
mainly because that they won't be receiving any more donations for PPE
Yeah.
if the donors and the national government would actually see
That
that
they
they
have
already
adequate
have
supply.
80% of the supply. So again, it's governance.
Yes,
again,
yes,
yeah.
yes.
Mhm.
Thank you, Pei. That's a good insight. Thank you for sharing that story. I think there are similar stories where people are not reporting because they might lose some incentives along the way. Thank you. And that's part of leadership and governance, understanding how people translate data and how people participate in data collection systems. Yeah, Dr. CP.
To my knowledge, I think we can look at Taiwan system and also Estonia system.
Mhm.
I think in Taiwan, they use the reimbursement to centralize the data.
Yeah.
So the reimbursement is by the government, but the provider actually largely are private. So they
Mhm.
have a system that is quite successful.
Yes.
So, and that will ensure the sort of data collection centralized because we need that centralized to make informed health decision.
Right.
Estonia, on the other hand, I understand, but I stand corrected that they have a very good system where the data are interchangeable. So to the GP, to the
Peer to
center.
peer.
Yes, I
Wow.
think, and so Estonia is one of the sort of example has been frequently brought up as how a what called fully digitized community should be. I think
Yeah.
we should look at that and see how
Okay.
it worked.
Okay. Thank you, Dr. CP. We can invite some of them. All right. Please. Taiwan and Estonia.
So just coming to COVID, what we have, we established the system from the government side. We set up for the tracking,
Yeah.
for the COVID tracking when people are enrolled in
Going,
the hospitals.
yeah.
COVID people are enrolled in the hospitals.
Mhm.
And that system is interoperable with all the 63 different hospital software. So any private hospital or government hospital, if they have a different software
Uh-huh.
that is interoperable with the COVID recording and reporting system, which we have developed.
Wow.
So then the government reimburse is for that data, that how many days they have stayed,
Mhm.
for how many in the ICU or in a SDU or in a general bed, and government reimburse is that part. So we have developed that sort of system from the ministries and given the API to the private sectors.
So there's technology,
Yeah,
interoperability, and reimbursement.
and reimbursement. That is all
Yes.
controlled with the systems.
Yeah.
And even it is connected with the laboratory softwares. It's not only the hospital management, but also with the laboratory softwares, because
How-
there are a lot of laboratory.
How long did you build that? I mean,
No, that is, I already mentioned that we already have a mother's tracking systems. We just convert that mother tracking system with that system.
so you were primed. You were already.
Yeah. So that I think I already have explained this one to Jay.
So maybe we can talk about that in one of the breakout. How
Right,
you were able
right,
to
right,
develop
right.
that. Thank you. Please approach Raj later on. That's amazing and impressive. How you were able to reuse old, reuse an existing software for the needs of the COVID-19. Okay, so we've reached the end of the workshop, and I'm happy to see a lot of the visions for digital health for your country. Please hold on to your visions. As I always joke with Dr. Bunchay, he should stop dreaming and start waking up. Because if he keeps on dreaming, then nothing will happen. He has to wake up from the dream so that we can start taking action for our country's digital health development. And with that, good afternoon, everyone. Thank you. We will take note of all of this output in the workshop and we will make it part of our conference proceedings. Thank you.